This is somewhat more distal. Here the bone quality is better with the custom 5 mm. Of course here it is poor, but if you see the myloid ridge is more prominent but more upward. But I think able to see the canal. Where is it? Maybe this one, right? This one. So we will measure the length. The shortest length of compressive is 8 mm. Even if you place 8 mm, it is coming close to the nerve. Okay, so resolved mandible. So what we can do is we can go still more distal. Still more distal. If you see the myloid ridge has come up more prominent, this depression is more. We can place the implant like this, that is more safer. Okay. So in highly resolved mandible, the more you go distally, the more safer and better quality bone is available. That's what I was trying to tell. Okay. If you remember the first molar area and all, this part is very less. Okay. And this bone is also not very proper. And nerve is also diffuse. But definitely here the nerve will be below this. I don't have to see the CPCT. Okay, even without CPCT we can do this lingual cortical. The only thing you have to keep your finger and do the drilling, feel the drill upon your finger, measure it and do it. So we will see the length here. So what implant to select? If I am placing compressive, it will be around 8. Okay. 8 mm diameter. If I am placing basal, it will be 10 mm. You have to include the soft tissue also. Soft tissue also. So our final plan is placing implant much distally by doing a lingual cortical engagement. And there is one more option also that we can see, just distal to the 5. Sometimes bone is available, we will see. Okay, so this is a surgical trick. Immediately distal to the 5 area, you will get a small safe zone. Okay. But the only problem is the canal is, where is the canal?
It's not here.
8 mm it shows, but of course we will be doing some plastic, so better to avoid. So this is 4, this is straightly to the south. So what is the small problem we are seeing here is, this inter-implant distance is very large. So it's a large bone. Somehow if you can place a short implant in between, that will be better able to take. Okay. So how to avoid this problem is, there is one more technique. What you can do is, what I am doing is, I am starting this implant from the 5 region and tilting mesial, similar to oral formula. Okay. So in the previous plan, I started from the 4 region, but now I am starting from the 5, but I am not going straight. I am tilting not slightly mesially, more mesially, so that the abutment comes, instead of here, it comes here. In that way, I am reducing the intercomplant distance. So these are the small changes we can do during the planning. Or if you don't want to this tilting and all, just put 4 and put this one, blue welling, that is enough, no problem. Now we will analyze the left side. Here I draw the nerve already. So this is the canal. Definitely we can place a short implant, 8 mm implant. Okay. Even if you do a little bit of alveoplasty, you can place a short implant here. We will see the 7 area. Okay. So this is the lingual bridge. This is the fossa. Okay. So you can place implant like this. Lingual cortical engagement. If you use your basal 3.6 12. You can place. This is near the sound region. So for heavily resolved cases, especially the distal resolved cases, the lingual cortical engagement is a very important technique. What I am telling is, many conventional people they struggle to restore these kind of cases when they don't see enough on the distal mandible. If they are doing all on foot, that is okay. If you are doing convention, you can do proper tilting and you can give all on foot also. Imagine you are not doing any distal implants, you are giving only all on foot convention, but you have to use the multi-unit abutment and a proper bar to connect the multi-unit. With single piece, this is the approach, either 6 or 8. So now procedure we have to visualize in the mind from start to beginning. What are all the challenges we may see here? What is the extensive alveoplasty we have to do? And we don't know how much attached gingiva this patient is having. Okay. Some good attached gingiva only. Flap reflection will be easy only. And alveoplasty. Difficulties, we have to list it out. Extraction, there may not be any difficulties or are predominantly weak only. Okay, bleeding also there may not be any issues, it is not very severe gingival inflammation. Procedural difficulty is one segment. Patient cooperation side, we have to see the difficulties. If the patient is very anxious, this kind of difficulties also. And mouth opening, this perioral mouth opening, they cannot, or very thick cheek, tongue is big. So these are all the difficulties that we should check before. We may think these are all small things, but during surgery they become a big thing and they are nice. So whenever you feel the patient is anxious, better to start anxiolytic or sedative.